MedSurg students, in this video I'm going to go over GI assessment and the biliary tree. Okay, so with GI assessment, the GI system is responsible for digestion and elimination, and digestion starts in the mouth. Okay, we have 32 teeth hopefully, so the saliva softens the food, the teeth help break down the food, and saliva contains amylase, which is also the enzyme that is released from the pancreas to help us digest food. The GI tract goes mouth to anus, so that's gut to butt. Okay, in some conditions, such as Crohn's disease, affects all of the GI tract. The esophagus is a long, hollow tube, goes from the mouth to the stomach. Okay, it passes through the diaphragm, and the lower esophageal sphincter, which is right at the bottom of the esophagus, helps prevent reflux. The stomach is in the left upper quadrant. It contains parietal cells that secrete hydrochloric acid, which helps us digest food, and intrinsic factor, which helps us absorb vitamin B12. So somebody who has a chronic problem like gastritis may have pernicious anemia because they can't absorb vitamin B12. Or if they've had bariatric surgery, which part of the stomach has been removed, they will have pernicious anemia for the rest of their life. Okay, as we age, we get lower esophageal weakness, and that's why elderly patients are at risk for aspiration. Oftentimes they have dentures, so they can't break down food in their mouth, and they have decreased function of taste buds. Food doesn't taste as well to them anymore. They have decreased hydrochloric acid, intrinsic factor, which puts them at risk for being malnourished, but also having vitamin B12 deficiency and pernicious anemia. All right, liver. The liver does a lot of things for us, as we learned in class. It makes bile. It makes albumin, which is a protein that we need. It's very important. Fibrinogen, which helps clotting. Globulins, which helps us fight infections. Clotting factors, which prevents us from bleeding. And cholesterol. All that to say is, if there's something wrong with your liver's not going to be able to do these things. It also is involved in metabolism and detoxifies toxins and medications in our body. Okay, physical assessment. When you're doing an abdominal assessment, the order you're going to go in is inspect, auscultate, percuss, and palpate. And you can remember the phrase, I am perfect pal, to remind you of that. You are going to have to know this, okay? When you inspect, you're going to inspect from two angles. Start in the right lower quadrant. Look for symmetry, scars, distension, and pulsations. You could also see hernias. Now with hernias, you're looking to see if the hernia is reducible. You're not going to do this though until after you've auscultated, right? You can palpate at the end. If the hernia cannot be moved back into place, it's called irreducible, or the other term for it is incarcerated. They are going to need surgical evaluation because this could lead to obstruction. It could also lead to strangulation. Now, don't confuse irreducible with strangulation. Okay, strangulation means like the hernia has turned on itself. This is like, see how it's turned here? And it becomes necrotic. Okay, so it may cut off the blood, it will cut off the blood supply to the bowel, and then the patient will be at risk for obstruction, necrosis, and perforations. So if you do see a strangulated hernia, that's a medical emergency. Look for tachycardia, abdominal distension, vomiting, that's fecal smelling, and fever. That could be a tip-off that there's a complete obstruction due to the strangulated hernia. Now, when we do auscultation, you expect to hear about 5 to 34 gurgles per minute. Hypoactive vowel sounds mean you don't hear anything for 30 seconds or more. Hyperactive is also called borborygmi. These are high-pitched, loud gurgling sounds. And if you hear that, it could mean there's an intestinal obstruction. If they're absent, you have to listen for 5 minutes to determine if vowel sounds are absent. Flatus means that there is peristalsis. So even if you have a hard time hearing it, if the patient is passing gas, they have vowel sounds. So I want to show you this little picture here with the vowel. So this is showing you an obstruction. Proximal to the obstruction, there's obstipation, which means there's no passage of stool or gas through the bowel, so it becomes distended, it fills with gas. This gas starts accumulating, and then you're going to hear borborygmi, okay, proximal to the obstruction, and then you're going to have hypoactive vowel sounds distal. Okay, so in one quadrant, you're going to have high-pitched tinkling vowel sounds, and in another quadrant, you're going to have hypoactive vowel sounds if there's an intestinal obstruction. And this is a full, complete obstruction or full obstruction. What happens is the bowel still keeps producing gas, okay, and the bowel is going to become distended, so you might see abdominal distension. Then it's going to keep getting bigger. It's going to compress on the veins and arteries. Okay, there's going to be edema of the bowel wall. Bacteria are going to collect. It's going to become necrotic. It could perforate, which is going to cause peritonitis, which peritonitis is highly tested. Okay, so you're going to have to know the cardinal sign is the board-like abdomen, high WBC, guarding, and pain and tenderness. And then your patient's going to have shock and they're going to die. So that's intestinal obstruction. Okay. Percussion and then palpation. Palpation is done last. Palpation, there's two types, light and deep. Light is used to detect masses, and you take your 4 fingers and you put them together and you use a rotational motion. And the reason I'm telling you this is this technique has shown up on proctors before. Note if there's any rigidity, and you palpate a 1/2 inch to 1 inch only. Deep palpation is reserved for providers, and so, but I want to show you the different hand techniques. So with light palpation, it's usually 1 hand, 4 fingers, rotational. With deep, it's use 2-hand technique. The bottom hand is really doing the palpation, and the top hand here is helping press deeply, okay? And that's usually reserved for providers. Laboratory assessment, the labs you're going to see in GI diseases. For CBC, that'll determine anemias, like I talked about, pernicious anemia, and infections. Prothrombin time is going to be prolonged in anybody with liver disease. It's the PT, not the PTT, okay? The potassium and sodium is going to be low in conditions where there's vomiting or diarrhea. The AST and the ALT and the ALP, alkaline phosphate, are going to be elevated in liver disorders. Amylase is going to be increased in pancreatitis. Lipase will be increased in pancreatitis, and that's the most accurate enzyme you'll look for in pancreatitis. Bilirubin will be high in obstructive jaundice, and ammonia will be high in liver failure. Fecal occult blood testing is highly tested. Okay, I think it's on 3 different proctors. So it's a screening tool. It's done every 5 years. Stool is smeared on a card. It doesn't need to be refrigerated. You need 3 samples from 3 different consecutive stools. And you use this, see this cup here? There's an applicator in here. So when you get your sample, you take this applicator and you stick it in 2 different areas of the stool to get the sample. You tell the patient they can't eat red meat, poultry, fish, or vitamin C foods for 3 days. No NSAIDs for 7 days. Okay, common tests, endoscopies. If somebody has a colonoscopy, that goes in through the anus. I think you know that, right? Um, these are all done under moderate sedation. So remember, the patient has to have a gag reflex when they wake up. You're checking for it before you give them anything. I want you to note that colonoscopy, EGD, sigmoidoscopy are all done on the left side because oftentimes you are asked about positioning, okay? With the EGD, the head of the bed is elevated. With colonoscopy, it's knees to chest. Now, colonoscopy, the first one is supposed to be done at age 50, and if that's good, you have another 10 years before you get another one. There is a bowel prep involved, and it's basically laxatives to clear out the bowel. You never want to drink red, orange, or purple fluids. And then for older adults, since they are going to have massive diarrhea when you take this prep, they're going to be at risk for metabolic acidosis. And after they have massive amounts of flatulence. And then the EGD, this is done to check for dilatations, for gastric lesions, and they're going to be MPO for 8 hours. So check the gag reflex after. In the ERCP, this is like done to diagnose or actually treat biliary conditions. All right, so they're going to be moved around a lot with their positioning. Sigmoidoscopy, that can be done bedside. It is a scope that looks at the sigmoid colon to detect cancer, and they're going to be put on their left side. And they will have a bowel prep as well. All right, let's go to the biliary tree and discuss the biliary tree. Okay, when we talk about the biliary tree, we're talking about the gallbladder, the pancreas, and the liver. The gallbladder is shaped like a pear, okay, pear-shaped organ. It's connected to the cystic duct. This is the common hepatic duct, and the liver's up here. The liver makes the bile. It travels down the common hepatic duct into the cystic duct, and it's stored by the gallbladder. So these terms you need to know. Cholelithiasis means gallstones. And gallstones are the most common reason people get cholecystitis, but they can get cholecystitis without gallstones as well. All right, cholecystitis is inflammation of the gallbladder. Choledocholithiasis is when a stone gets caught in this common bile duct, okay? Cholangitis is, say you had this stone in your common bile duct. This is a medical emergency. Your patient's going to turn jaundice right away. They're going to have pain in the right upper quadrant, and they are going to have a high fever. Okay, and what they would do is they would do an ERCP and try to extract that stone. Okay, so cholecystitis, we talked about its inflammation of the gallbladder wall, most commonly due to cholelithiasis, but it can be due to acalculous conditions, and it can be acute or chronic. Risk factors include the 6 F's. Fair, which means Caucasian, fat, 40, female, family, meaning it's genetic, it has a genetic tendency, and fertile. The risk factors include eating a high-fat diet, because when you eat fat, your gallbladder starts contracting. And that's why people with cholecystitis have a lot of pain after they eat high-fat foods. A sedentary lifestyle, a BMI greater than 30, Crohn's disease, starvation. So if you go on a starvation diet, that stresses your liver out. When your liver gets stressed, it makes more cholesterol. High cholesterol, for some reason, causes cholecystitis. So starvation diets are a risk factor. Insulin resistance, so people with diabetes type 2 especially are going to be at risk for cholecystitis and rapid weight loss, which goes along with the starvation. Okay, cholecystitis, recognizing the cues. Your patient is going to have pain in the right upper quadrant after eating fatty foods with radiation to the right shoulder. They're going to have a temperature because it's inflammation of the gallbladder, nausea and vomiting, dyspepsia, which is heartburn, eructication, which is burping, flatulence, so they have gas coming out of both ends, and then Murphy sign. Murphy sign is something the provider would elicit on deep palpation, and it's pain in the right upper quadrant while the provider's pressing on it, and rebound tenderness, which would be done in deep palpation during palpation. Biliary obstruction. Okay, this can happen with chronic cholecystitis. It can also happen with choledocholithiasis. So your patient is going to be jaundice. They're going to have icterus, clay-colored stools, steatorrhea, which is fatty stools because the bile is not going into the GI tract, and dark foamy urine and pruritus. We did a concept map in class that showed you how this occurs. And I'm going to show you at the end of this as well. Okay, lab tests. If somebody is obstructed, they will have a high bilirubin, and if it's obstructed near the pancreas and the pancreas is involved, they will have high amylase and lipase. High alkaline phosphate and AST and ALT are high when there's obstructive jaundice. And I'm going to show you a picture of that later. Okay, diagnostic testing. The most non-invasive is going to be the ultrasound, so they would do that first. MCRP is a MRI basically of the gallbladder. Remember, you have to check the BUN and creatinine and hold metformin. They can't have any metal in their body before they have this test, and check for delayed allergies after. All right, treatment. There's a lot of different treatments. Do nothing. You can do nothing. Put them on a low-fat diet. They could engage in weight loss. They can have bile-dissolving medications. The drugs they're going to be treated with during an episode would be opioids and ketorolac. They can have ESWL, we talked about in that class, and you're going to monitor for dysrhythmias after. Or they could have a lap chole, which is less invasive than an open chole. And they wake up with like 4 of these little 2x2s when they come to the PACU, and there's usually one on the umbilicus too. Now, to do a laparoscopic cholecystectomy, the abdomen is filled with gas, so the surgeon can see what they're doing. So when they come out, they're going to complain. When I say come out, I mean when they come to the PACU and they start waking up, they're going to complain about pain in their shoulder and thorax because the gas rises and it gets stuck in their shoulder. So the best thing to do is make the patient ambulate. That'll move the gas around so they can start passing it. Medicate for turn, cough, deep breathe. Okay, if you notice, the scars here for an open or a lap are right where the respiratory muscles are. So it hurts to breathe, and you have to breathe after. So you have to medicate your patient so they will breathe. Open cholecystectomy is now reserved for like severe biliary obstruction, like say somebody had choledocholithiasis and they were unable to extract the stone with an ERCP. They may have to go in and take it out, okay? They're going to have a JP drain. They'll have bile stained fluid for 24 hours. They could have a T-tube, and I'll show you a picture of that. Turn the client to assess bleeding. Anybody that's had surgery, you have to turn them to assess for bleeding. Turn, cough, deep breathe is going to be really painful, so you need to medicate them to make sure they're doing that and using their incentive spirometer. This is a T-tube. It's called a T-tube because it's shaped like the letter T. It goes in the common bile duct if there's been an exploration in the common bile duct. and it goes outside the body to a drainage collection tube, and it drains bile. You expect a lot, 500 to 1,000 mLs per day. Okay, monitor for peritonitis. Okay, acute pancreatitis, we did a concept map in class. Remember, this results from usually the two most common causes are alcohol abuse, like a binge, or biliary obstruction. Those are the two most common reasons somebody has pancreatitis. So, for one of those reasons, what happens is this makes the digestive enzymes release early, whatever the trigger is. And then it starts auto-digesting the pancreas. So the pain assessment, the patient is going to have mid-epigastric to left upper quadrant pain. It's sudden, it radiates to the back, left flank, and shoulder, and it waxes and wanes, okay? So it's going to be, up and down. It's intense, it's boring, meaning they feel like it's going through their body, and their client will guard. You may not be able to palpate the abdomen. Keep the patient NPO. This helps with pain because if the patient's not NPO, those digestive enzymes are going to keep secreting. Maintain bed rest. That'll decrease your metabolism. That also helps with pain. Pain is worse in the supine position. Patients like fetal position or sitting up and leaning forward to relieve the pain. All right, so the expected findings. Patient may lose weight, they may have nausea and vomiting. Culling sign is bleeding around, is bruising around the umbilicus. Gray Turner sign is bruising of the flanks. And these signs could indicate a bleed, like a hemorrhagic bleed, or could be from hemorrhagic exudates. But it's indicative of pancreatitis. They could have a paralytic ileus, meaning they don't have any bowel sounds, then there's no peristalsis and they would need an NG tube. They could have jaundice if it's due to biliary stones and fruity breath. Patients with pancreatitis have hypocalcemia. That's one of the electrolyte disorders you have to monitor for. So you know how to do that. Abdominal assessment, we've talked, you would do that. So the WBCs are going to be elevated. If it's due to a stone, alkaline phosphatase, bilirubin, ALT, and AST are going to be elevated. The BUN is going to be elevated due to third spacing. Amylase will be elevated and stays elevated for 2 to 3 days. Lipase is more specific, and it stays elevated for 7 to 10 days. So that's like the gold standard, the lipase, and it'll be increased. I talked about albumin being decreased, calcium being decreased, and prealbumin may be decreased. Now, prealbumin is the most specific lab that is done to determine if somebody is malnourished, okay? Because it determines if they're malnourished acutely. So that's the most specific. And so that would be low. Okay, data collection. So remember your ABCDs when you're talking about priorities. They can get, because of pancreatitis, they can get pleural effusions, they can get ARDS, so acute respiratory distress syndrome. So all that to say is you need to do a respiratory assessment Q4 hours. O2 PRN, in the C category, you want to get 2 large bore IVs because they may need fluid resuscitation because typically they're not going to be able to eat. They're going to be NPO on bed rest and need a PCA. They may need antiemetics. They may need an NG tube if they don't have bowel sounds, and monitor for hypocalcemia. Okay, when they have no pain, they can start eating again. It's going to be small, frequent meals and snacks. Make sure it's food that's bland, not spicy food, no caffeine, no alcohol, It needs to be low fat. That's super important because fat makes the pancreatic enzymes increase. The diet's going to be high carbs, high protein, low fat initially. No smoking, definitely. Now, chronic pancreatitis can happen over years of having bouts of pancreatitis. It's usually due to alcohol abuse. The patient, who is an adult, will develop type 1 diabetes. Anytime an adult has type 1 diabetes, it causes you to pause that maybe there's something wrong with the pancreas if that happens, because usually this occurs first in childhood. Monitor for the 3 Ps of diabetes. They're going to be malnourished because the exocrine function of the pancreas is involved in nutrition, breaking down our food, etc. So they'll be malnourished. They'll have steatorrhea, that's fatty stools. They'll be jaundice and have dark foamy urine. Okay, so PERT therapy. This is pancreatic enzyme replacement therapy. They need to use this. This is for chronic only, with all meals and snacks. Okay, they cannot chew or crush. They do not administer with protein foods, and pierce a hole in the medication, and you can sprinkle it in food if they can't swallow it. Wipe the lips after administration because it's going to, remember, it breaks down protein, and if you leave it on the lips, it's going to make them irritated. Okay, so as when they go home, they're going to be taught to eat a low-fat diet. They need to avoid alcohol. They need to avoid high-fat foods, anything that makes symptoms worse, like nicotine, caffeine, alcohol. They can't have any of that. Okay, activity. Their living area will be limited to 1 floor until they regain their strength. So you need to make sure there's a commode nearby, especially for chronic, because they're going to be on the toilet a lot. All right, let's switch gears and talk about hepatitis. This is an infection of the liver, and it's a viral infection. So for A, B, and C, you need to know how it's transmitted. So A is for anus, so remember fecal oral. B is for blood and booty fluids, so patients can transmit it that way. And then C is really the same as B, okay? So you don't have to memorize a bunch of things. But read through that. We talked about it in class. Make sure you know how everything's transmitted, how to prevent it, and how it's treated. Okay, that's going to be important. And the danger is B and C can turn into cirrhosis, and then it can turn into liver failure, liver cancer. So that's why you're watching that. Expected findings, whether it's A, B, and C, the findings are all the same. So they're going to have pain in the right upper quadrant. Their liver may be inflamed, fever, nausea, and vomiting, joint pain, muscle pain. So they just don't feel good. If they have biliary obstruction, they're going to have jaundice and icterus, dark foamy urine, clay-colored stool, pruritus, which is itching because the bile salts get stuck under the skin, excoriations from scratching so much. They'll have an elevated AST, ALT, ALP, and bilirubin. So biliary obstruction is biliary obstruction. They're going to have these labs, whether it's hepatitis, chronic cholecystitis, liver problems, any type of biliary obstruction will have these signs and symptoms. A liver biopsy can be done to determine, like, if a patient has cirrhosis or any kind of liver disease and they're not sure what it is. So the patient needs to be NPO. It's invasive, so they need informed consent. You're going to do coagulation studies pre-procedure because the liver is really vascular, Instruct the patient to exhale and hold the breath for 10 seconds while the provider is doing it so that they don't get a pneumothorax. Monitor for bleeding after. You're looking for tachycardia, then tachypnea, then a drop blood pressure. Don't miss those signs, early signs. Monitor for bleeding, and then keep the patient on the right side for 2 hours to enhance coagulation post-procedure. All right, cirrhosis. Cirrhosis occurs over a lot of years, okay? So it could be like 35 years, and there's no signs and symptoms early on. This is why it progresses, okay? Expected findings are nondescript early, okay? So they'll have fatigue and weakness, anorexia and weight loss, dyspnea, abdominal pain and distension, confusion, and emotional lability, meaning their emotions are all over the place. Portal hypertension occurs in late cirrhosis, okay? And if you look at this picture, look at the liver. This is the portal vein. When the liver becomes fibrotic, this blood cannot flow into the liver anymore and it backs up. It's called a portal system. It causes splenomegaly. Splenomegaly, when the spleen gets big, it acts as a Pac-Man and eats all the blood cells. So it eats the platelets, it eats the red blood cells, and it eats the white blood cells. So your patient is going to have anemia, thrombocytopenia, and leukopenia. All right, they're going to have ascites due to this portal hypertension. Ascites, I have a picture lower that you'll be able to see. They'll have caput medusae, which is snake-like veins of their abdomen. They'll have hemorrhoids. They'll have esophageal varices, which they can bleed out and die from, so that's dangerous. They can get a hepatic encephalopathy, which is also called portal systemic encephalopathy, and I talked about the splenomegaly. So portal hypertension causes a lot of different things. And here are some pictures of that people with liver disease. Here's ascites. Here's caput medusae. Here's purpura, and here's bruising from the bleeding tendencies. So ascites is fluid in the peritoneal cavity. When this gets really big, it's hard for patients to breathe. So they may do a paracentesis if they're having trouble breathing. They're going to be prone to left pleural effusions. The head of the bed should be 30 with the feet elevated. Measure the abdominal girth daily. They need daily weights, potentially a low sodium diet, and diuretics. Paracentesis is done to relieve the respiratory effort, or if they think the patient has peritonitis. Okay, so way before and after, the patient needs to void before. Make sure you're doing your post-procedural vital signs and monitor for peritonitis times 48 hours. You're also going to monitor for hypovolemic shock, so look for your tachycardia, then tachypnea, then a drop blood pressure. All right, for esophageal varices, screening is done for all clients with varices. If anybody that has cirrhosis needs to be screened, and they'll be put on a non-selective beta blocker, so that's propranolol. There's two medications that they can be treated with. One is called octreotide, and this is safe for patients with cardiac disease. And the other is vasopressin when they're bleeding. So vasopressin is not safe for somebody with cardiac disease because they could end up with an MI. They go to endoscopy to get either ligation or they'll cut off the varices. They could also get balloon tamponade, which I'm going to talk about. They'll get packed red blood cells if they're bleeding, FFP, which is fresh frozen plasma, which contains all the clotting factors. Remember, patients with cirrhosis cannot make their clotting factors, so they may need that, and platelets, because remember, they could have thrombocytopenia. Monitor the respiratory system, because if they're vomiting all that blood, you don't want them to aspirate. But also, if somebody has esophageal varices, you have to monitor the neurological system very closely because blood is going to be digested as protein. And if patients with cirrhosis eat protein, the ammonia level in their body is going to go up and they'll get confused. Okay. This is balloon tamponade. It's called Sensaken Blakemore tube. It's not commonly used, but it's highly tested because it's dangerous. There's 3 ports, one to blow up the esophageal balloon, one to blow up the stomach balloon, and also just like a regular NG tube. Okay. Now, what can happen is if this migrates up, it can occlude the airway. So you need to have scissors in the room at all times so you can cut the balloons and pull it out. Okay, portal systemic encephalopathy. This happens when there's increased ammonia in the blood. The patient's going to have a decreased LOC. They could have asteristics. They could have slurred speech, reversal of their sleep-wake cycle, positive Babinski. So all this to say is that ammonia is neurotoxic to the body. So they're going to have neurological signs. So the asteristics and hand tremors and peripheral neuropathy. Okay, now the good news is if you discover your patient has developed asteristics, it's like 4 different stages of portal systemic encephalopathy, and you don't need to know what happens in each stage, but what you do need to know is you have to recognize it. They can be put on lactulose, and they can then go down to a lower stage. So that's why it's important to jump on if you see any of these signs and symptoms to let this provider know. All right, so lactulose decreases the pH of the bowel, so it decreases ammonia production, and it facilitates the excretion of ammonia in the stool. The patient should have 2 to 3 soft BMs per day, and then that should improve the encephalopathy. With estrogen effects, because remember the liver cannot detoxify hormones, okay, patients are going to have spider angioma, they're going to have palmar erythema, warm red hands. Men will be impotent. Women will be infertile. And gynecomastia will occur on men. And they'll have loss of body hair. So those are the estrogen effects because estrogen cannot be broken down. Now, early in cirrhosis, they may have an increase in the liver function studies. But over time, the liver may not be able to make those enzymes anymore. Okay? The bilirubin will be high, the ammonia will be high, the PT will be prolonged, the INR will be prolonged, protein and albumin will be low, platelets will be low, hemoglobin will be low, glucose could be high or low, and then the WBC is going to be low. All right, for skin and hygienic care. So those bile salts are super itchy under the skin. So you want to use tepid or cool water on the skin. Don't use strong soaps, pat dry. Use moisturizing creams. You can put gloves on their hands to prevent them from scratching. They're going to need bleeding precautions, so remember everything in bleeding precautions. All right, the diet in end stage. Now, if they have ascites, they may be put on a low sodium diet, low protein diet if they have PSE, and soft foods if they have varices, because you don't want like a piece of toast to nick one of those varices and they start bleeding. Small, frequent, well-balanced meals. They'll be put on thiamine, which helps prevent Wernicke's encephalopathy, which is a different kind of encephalopathy. Fluid restriction, possibly for ascites, and no alcohol. And we did this little man diagram in class, so remember all the signs and symptoms. Okay, just as an overview, okay, this is the liver. The liver makes bile. The bile travels down. the hepatic ducts, goes into the cystic duct, okay, and it's stored in the gallbladder until we need it, which is when we eat a fatty meal. Okay, here's the common bile duct, and the pancreatic enzymes go into the common bile duct, and then it goes into the duodenum. Okay, so the conditions we talked about are cholelithiasis. These are gallstones. It's the most common reason people have cholecystitis. However, you can have gallstones and not even know it. Okay, cholecystitis is a little more serious. That's inflammation of the gallbladder. Choledocholithiasis occurs when a stone gets stuck in the common bile duct. If a stone gets stuck in the common bile duct, okay, that means the liver is going to keep making bile. It's going to flow down, but it's going to get obstructed. The bile can't flow, so it's going to leak into the blood system. So the liver is going to get extremely stressed if the bile starts backing up into the liver. And so you're going to have an increase in your liver enzymes, an increase in bilirubin if there's a stone in the common bile duct, right? We call this biliary obstruction. The signs and symptoms you'll see are jaundice, icterus, itchiness, clay-colored stool, dark form of urine, and intolerance to fatty foods. Okay. Now, if there's cholecystitis, remember the 6 F's, those are the causes. And then the signs and symptoms include pain in the right upper quadrant, especially after eating fatty foods, high white count, they're going to have a temperature, positive Murphy sign, you may read that in the chart, rebound tenderness, eructication and flatulence, and nausea and vomiting. And then remember the operations of proper abdominal assessment and then the treatment we talked about. Now, if a stone gets lodged right here, it's going to impede the pancreatic enzymes. So that's why they can get pancreatitis from biliary obstruction. All right, so that does it for GI assessment and the biliary tree.